Welcome, everyone. I'm so glad you could join us today. My name's Aline Sigler. I'm with Provider Outreach and Education. Also on the line with me today is my friend and coworker, Leanne Foster. She's serving as my co-host today. She's my superhero behind the screens. I want to thank her for her assistance. You'll see her add things to the chat, monitoring the chat for me, kind of my eyes and ears behind the scenes, if you will. So I couldn't do this without her. Now, this session today is part of a recurring series that we've been doing for the last year or so, where every quarter we're examining frequent error codes and their resolutions for our Part A providers. There is a similar series for Part B providers that bill on the CMS 1500 claim form, analyzing claims from different specialties. So it's separate webinars. Today we're focusing on inpatient hospital claims. So as I mentioned, the purpose of this webinar is to review some of the most common reason codes that we see on inpatient hospital claims. Our goal is to avoid errors that result in unpaid claims. We get paid to be a claims processing contractor. The only stipulation to that is we have to make those payments properly. So when claims aren't paid, we analyze the reason behind that. And then what can we do to pay those claims for you and get them processed correctly? So we're going to begin with where we got the information we're going to be discussing today and what that data shows. We're going to look at the top categories of edits and then decipher ways to correct and hopefully keep them from happening in the future. Now, even if you haven't received any of these particular errors that we're going to be discussing, this information will help you if you ever do. At the end of our time today, we're going to finish up with some resources. Where can you go to see that information in black and white? Where are those rules? Where does it say you can or cannot bill a particular way or for a particular item? We like to take you back to those regulations. So it's not just a he said, she said sort of situation. So those resources will help you get more information on the different topics that we're going to cover. Here at WPS, we have multiple business units or departments that review claims on a very consistent basis, constantly, actually. And we do that for a lot of different reasons. We each have our own special nook of work that we do within these different departments, different pieces within the claims processing puzzle that we work on. And we have a database that we can all look at. It continuously rolls up claim specifics. And so I was able to look at and filter that data to find the pool of claims that we're going to be talking about today. The time frame is very important. So what window of time are we looking at? So those are claims that were submitted between February 1st and April 30th of this year. Now this is important because again, it's claims that were submitted between those dates, not necessarily based on the date of service. So I want to clarify that. According to submission date, not necessarily date of service. I filtered for rejected, returned, and denied claims. Because if we can catch and correct edits before they reject, then we can save ourselves the time and expense of making adjustments, appealing claims, or rebilling. So it's about efficiency. It's about proper payment, but it's also about efficiency because time is money. It costs money to reprocess a claim. It costs money to appeal something that should have been paid. And so we want to look at that and analyze that. I also filtered for just the bill types that you see here. So since we're specifically focusing on inpatient hospital claims, I asked that database to show me claims that were billed on a 1-1X type of bill and a 1-2X for those inpatient Part B claims. After sorting that information, you can see I was given 15,619 claims for that time period. And then I filtered those results for the reasons behind them being unpaid. So we had 7,498 claims that were rejected. Now in the FIS world, which is the Part A claims processing system, Fiscal Intermediary Standard System, rejected means that there's a technical issue or a billing error on the claim. We had 5,125 claims that errored out and were sent back to the provider's online location for correction. This is status location TB9997. If you're new to FIS, if you're new to Medicare, you're not familiar with direct data entry, some of these terms are just coming at you out of left field. So I'm trying to pause and define them for you. Within the Part A claims processing system, we can send claims back to a provider electronically to a provider's online file or queue, because whatever is missing or whatever is incorrect has to be completed by the provider. So the claim's not finalized, but it's not paid because it won't go any further without action from the provider. And then lastly, there were 2,969 claims that were denied. The term denied in FIS terms is for some question of medical necessity or some coverage criteria, something that's more clinical in nature. I know I'm guilty of this, using the terms rejected and denied interchangeably. I might say something denied as a duplicate, but when we look at these definitions, we see that it's rejected as a duplicate. Again, I fully admit that I make that mistake in using those terms interchangeably, but for technical terms, I wanted to define them for you because they're different, and the actions that you take to correct those edits or errors is different also, depending on what's actually going on with it. So the total amount for these 15,000 and some claims was $35,817,168 total dollars that were non-covered for inpatient hospital claims during this time period. Now this slide, I added this just to illustrate the background or the breakdown, of those same statistics by contract. If you're not familiar, Jurisdiction 5 consists of the states of Iowa, Kansas, Nebraska, and Missouri. It also includes some facilities in other states across the country that are part of a chain or healthcare organization. And then Jurisdiction 8 consists of Indiana and Michigan. So I added the numbers here just so you can see where you fit into this data snapshot. Not to say one jurisdiction is doing better than another or anything like that, because we don't have the same number of providers. We don't have the same number of claims coming in from either contract. So again, just to see where your claims fall in the grand scheme of things. So when I was looking at this report, as you can imagine, that data showed a variety of error codes. This has hundreds, if not thousands, of reason codes. Reason codes are edits or error codes. The description, or what we call the narrative of these reason codes, can be very similar. So when I was looking at that database and looking at that report, I took the most prevalent ones and I combined them into the categories that we're going to look at in just a moment. So I tried to group them together. We'll go over these in more detail. That'll give you a better idea of what the reason code is and what to do about them. And I do need to just give you a little disclaimer here that I did bypass denials or rejections where a claim was billed non-covered on purpose. So it was unpaid, but it's not necessarily an error, because as you learn more about Medicare, you'll realize sometimes we have to do that. We're not expecting payment from Medicare, but for reporting purposes or other reasons, we still need to file a claim with Medicare. So I kind of took those out of the mix. So we want to break down these unpaid claims even further by contract. And so we're going to look at these based on the type of bill, and that's what we're going to do next. So on the inpatient Part A claims and our data sample, here are the top 5 categories of errors. So I'm just going to go down the list and then we'll explore them more in a few minutes. We had benefits are exhausted. Medicare is not the primary payer. Beneficiary is incarcerated. Incorrect discharge status, and insufficient or missing documentation. I know those are very general categories, but again, we're going to look at them more. Now for the inpatient Part B claims that are billed on a 1-2X type of bill, we also saw claims that weren't submitted timely, revenue codes that weren't allowed, services not separately payable, services on the same date as an inpatient procedure, and then we also had some errors regarding the National Correct Coding Initiative, or NCCI, code pair edits. So as we jump in and take a closer look at these different error categories, we're going to review the reason code or codes that appeared on the claims data report. We're going to briefly explain what its definition is, and then we're going to discuss what we can do to correct and prevent them. And I just kind of went in order as far as each of the different bill types and those lists that we just looked at. I just kind of went down the list. Now, if an error category is listed on both bill types, we're only going to discuss it once. There wouldn't be any need to do that more than once. So a beneficiary is in an inpatient hospital stay, and they have a specific number of days per benefit period. You might hear this referred to as a spell of illness. Once these days have been used up, then the claims will reject with the reason codes that you see here. These are the 2 that appeared on the data that I looked at for this time period. 70IBE and 70PBE. Now, 70 PBE is specific to psychiatric hospital days. Sometimes our reason codes give us a clue as to what the issue is just by what it is. So PBE, psych benefits exhaust. And then likewise, IBE stands for inpatient benefits exhaust. So this means there were no hospital days remaining for services that were subject to the benefit period determinations, or inpatient lifetime psychiatric days are exhausted. So if you think that there's an error on your claim because you weren't expecting the patient to be out of days, check their eligibility. Did they use days at a different facility that maybe you weren't aware of? Like maybe they were in a hospital, but both you and the patient thought they were in observation, not admitted as an inpatient. Maybe when you or someone else at your office or facility initially checked benefits, a prior stay that occurred within the past 60 days hadn't been billed yet. So it looked like the patient had more days remaining in their benefit period than they did. We do the best we can by checking eligibility, knowing where the patient's at. But for some of our beneficiaries who are in and out of stays, and depending on their mental capacity and their cognition, they may not remember or they may not realize what a benefit period is or how many days they have. When you're sick, that's not the best time to start learning about how your benefits work. And so dealing with the population that we do, sometimes there's confusion about that. Common working file, which is the patient's master record, is only going to reflect days taken away from the benefit period after claims are processed. So if there's a claim from another facility hanging out there that hasn't processed yet, those days haven't been taken away. And so in the interim, before your claim comes in, things can change. When billing claims where benefits are exhausting, you're going to want to bill all days and charges as covered, as if the patient had days left. And that might seem kind of strange to say when we tell you to be careful and monitor the days and know where the patient is. But it's actually written this way in the internet-only manuals. And the reason for this is so that the system can apply any days that are remaining when the claim is getting ready to process. So this means a couple different things, a couple different billing elements on your claim. The value code 09 for the coinsurance. Bill that with just $1. So use that 09, use $1, and let the system calculate the exact coinsurance amount that's due. Usually you know the benefits are exhaust, so there's no real error in that. But the claim might have errors based on the way that it's submitted. So we're trying to help with that. In some ways, providers can be too proactive in trying to figure that coinsurance to the nearest dollar, only to have an error because, like I said, some of those other claims come in and switch things around a little bit. The last bullet here, this is for anybody who might not be aware that inpatient claims from hospitals are processed on a first in, first out basis and not in sequential order like skilled nursing facility claims. So if you have a patient that is in and out of the hospital, that's going to play a part in how their benefit days are utilized. So I just want to make sure that everybody is aware of that, because even if they had a claim at a hospital last month and they just discharged from your facility today, your claim could process, use the remaining days in the benefit period, and that prior claim could actually be benefits exhaust, and that's totally normal. Moving on. The data every quarter consistently shows a series of reason codes pertaining to other insurance. So the claims aren't paid because our records indicate Medicare is not the primary payer. Beneficiaries don't have to stop working just because they reach age 65. They may have a spouse that's still working and covering them on a group health plan. There could be a lot of different scenarios here. When we're talking about Medicare and other insurance, there's a series of reason codes, and they all begin with a 3-4. If you know anything about the fiscal intermediary standard system and reason codes and status locations and drivers and all of these other terms, you'll know that most reasons for edits are in a series of numbers. There's a range of numbers. So if you see a reason code that starts with a 3-4, there's probably something to do with another insurance involved here. So rather than list out all the different types of insurance because they all have a different reason code associated with them, I just used 34XXX, and those X's can vary depending on the type of insurance that the patient's record is showing as active and possibly primary to Medicare. So our sample showed some for working aged, which is the employer group health plans, disability insurance, which is a large group health plan, workers' compensation, and auto no fault. So those are the types that showed up in our data report. Now, depending on what type of insurance it is, really doesn't matter because the steps that you're going to take to investigate and correct it will be very similar. So if you get a reject concerning other coverage, double check the beneficiary's master record. As a Part A provider, you are required to check eligibility or ask the patient or their representative questions about other coverage. We call this the MSP questionnaire. So you can do the MSP questions or use an electronic means to check eligibility. And you're going to do this at every admission, every outpatient encounter, and at the start of care and every 90 days for recurring services. Ask the patient, has something changed since they last came in or they were last admitted to your facility? Did their spouse change jobs or insurances? If the information on the patient's file is incorrect, let's say they retired at the end of last year, but their retirement date wasn't added, you might have to contact the Benefits Coordination and Recovery Center. Of course, it has an acronym, BCRC. They are the ones that are able to update the records. They're a specialized contractor, and that is the main part of what they do. That's why they're called Benefits Coordination. If you want information on how the BCRC works for CMS, how they can assist you, go to the CMS website. You can literally just put BCRC in the search and it will come up for you. You can also use a term like coordination of benefits or COB. You're going to find their phone number, their hours of operation, all kinds of different information. Now, through your research, if you determine that your patient does indeed have another insurance that should be responsible for the claim, go ahead and send that bill to them and then send a secondary claim to Medicare once they've processed it. That Medicare claim is going to include the payment or the denial information, and you report that with specific coding requirements based on the situation and the type of insurance. Now, CMS does have some really good resources, some tools that can help you learn more. There are a couple listed on the resource slide. There's a couple of those towards the end of our PowerPoint presentation. We'll look at that. If you've downloaded it, you'll see it there. Couple places where you can go to get more information. You can also check out our YouTube channel. We have an MSP, Medicare Secondary Payer playlist that can help you as well. On to the next category of errors, and that is beneficiaries incarcerated. Excuse me. This reason code U540A. That indicates that a Medicare claim was denied because the beneficiary was listed as incarcerated in Social Security's records. Now, I mentioned earlier that sometimes reason codes give you a clue. If you see a reason code that starts with a letter, an E, a C, a U, a W, that indicates it's a common working file edit. U stands for utilization. That's kind of off the subject, but just a little information there for you. So in these cases, Medicare cannot pay for the services because they are payable by another government entity. CMS presumes that a state or local government that has custody of a Medicare beneficiary under a penal statute has the financial obligation to pay for the cost of healthcare items and services for that person at that time. There are some exceptions. We'll talk about those in just a moment. But first, let's talk about Medicare's definition of in custody. That could include any of the items you see listed here. It's not an all-inclusive list, but some examples. Under arrest, incarcerated, imprisoned, escaped from confinement, on medical furlough, or required by criminal law to reside in mental health facilities. There were some changes at the beginning of 2025. So some of the things that were previously considered in custody are no longer. And one of the ones that comes to mind is home detention. There is a link to a Medicare Learning Network fact sheet on your resource slide that can give you more information and help you define some of these things if this is a situation you haven't come across in your claims billing and processing before. Now, if you have a claim rejected for this reason, check for ineligible periods due to incarceration in our provider portal known as SNAP, Secure Net Access Portal. If the beneficiary was not actually incarcerated dates of service, the beneficiary has to update his or her status with Medicare and Social Security. CMS gets incarceration and custody data from the Social Security Administration. Now keep in mind that's reported by the penal facility. So their reporting practices could also delay the release of data. So there's a time frame in there where it just takes time to get that information updated. When patients contact the Social Security Administration requesting benefits reinstatement, this also updates the release data in our system and allows Medicare claims to process. I mentioned that Medicare does have some exceptions from when they may pay, and they're outlined here. So number one, the state or local law requires individuals to repay the cost of their medical items and services that they get while they're in custody. The state or local government entity enforces the payment requirement by billing and seeking collection from all such individuals in custody with the same legal status. So, for example, not guilty by reason of insanity. So, whether they're insured or uninsured. Number three, it also has to pursue collection of the amounts owed in the same manner and with the same effort that it pursues other debt collection. So this includes any Medicare deductibles and coinsurance amounts and the costs of items and services that we don't cover. If requested, the state or local entity has to provide evidence of those routine collection efforts and their rules or procedures that are used to bill and collect amounts paid for an incarcerated individual's medical expenses. So not just that they have to have the process, they have to provide documentation of that process if asked. If the exception is met, there is a modifier that you can use. It's QJ. There's also condition code 63, and then there are verbatim remarks that you see here in the last line on this slide, and you would want to type it in verbatim, exactly like it showed here, the same abbreviations, the same spacing, everything. Approved, Inc for incarcerated, and then Benny for beneficiary. Now, the next two reason codes haven't been in the top 5 for the last several quarters. I'm not sure why that is, but we're here to discuss it and talk about solutions to keep them out of next quarter's report. So we have C7111. The discharge date of this claim is equal to the admission date of a posted claim. The other one that showed up, and I grouped them together, because they're similar, E7272. So they both start with a letter. They're both common working file edits. C stands for crossover and E stands for something I can't remember, but they are both common working file edits. And definition of E7272, inpatient claim with incorrect patient status due to transfer to another facility. So they're dealing with an incorrect discharge status code, and that's why I put them together. So I'm sure that when your facility submitted your claim to Medicare, you did it to the best of your ability with the information that you were given. We are all human. Sometimes things get overlooked and left out, but there are some things that we can do, So a couple things I suggest is to check the patient's record. Maybe you saw discharge to home, which is a 01, but you missed the next line that said to begin home health, which would actually then make the discharge status a 06. You can check with the patient or their family. Were they sent home from your hospital, but got sick or hurt later that day and were admitted to the facility across town without your knowledge? If you know who the other facility is, you can check with them to verify that the date that they have is correct. Because when we look at these edits, it's either the dates are wrong or the discharge status is wrong. If you're a registered user of our portal, you can log into the portal, look for information about the other facility. There is overlap information there. Now, once you determine what the actual problem is and what that correct patient status code or discharge date should be, you can correct your claim by either adjusting it or resubmitting it. The next set of reason codes pertain to recovery audit contractor reviews. Yes, we have an acronym, RAC, R-A-C, stands for Recovery Audit Contractor. Now, the RAC is a separate contractor. They work for CMS, and they conduct post-payment reviews. The reason codes contain the RAC acronym right in it. 5 RACB, 5 RACH. So that's a clue for you. 5 RACB states that information was received, but it was determined to be incomplete or insufficient in some way. So there was either key pieces of information missing, maybe depending on how it was sent in, the whole fax didn't go through, part of it was lost in the mail. It could just be a number of things. And then the reason code 5 RACH states that there was no response. No documentation was received within the allotted amount of time. So we don't want this to happen, because if you're going to be assessed in error and your money's going to be taken back, we want there to be a good reason for it. We don't want it to happen, but if it does happen, we want it to be justifiable. No response, to me, is not an accurate reflection of how you billed, how you documented, or how we processed it as your MAC. So we recommend that you review the RAC list of approved issues. If you're not familiar with how the RAC works, They propose service types or facility types that they want to review. They submit that to CMS, and CMS either says, yep, go ahead with the review, or no. So there is a list of approved topics published on their website. So take a look at that and just kind of become familiar with the types of services and provider types that CMS has given them permission to review. If it's something you review for, or you are that provider type, then you'll be watching for those review requests, those documentation requests, excuse me. And so you'll kind of have a jump on it. All J5 and J8 states are in RAC regions 1 and 2, and that contract is held by Performant Recovery. Now, I failed to get their information onto the resource slides, but I've asked Leanne to place a link to it in the chat for you. And this is where you can go on their website to review those lists of approved topics. Another thing I suggest that you do is determine who in office to handle those requests if they come in, and have a plan in place so that once a request for documentation is received, it gets to the right person or area. Make note of the deadlines in which to submit medical records. There's also a place on their website where you can confirm your contact information, which should also help it get to the right place the first time. We'll also drop a link to that in the chat, because again, if you've never had a RAC request, this is about it. You'll just want to become aware. So if you get a request, it doesn't get lost, it doesn't sit on someone's desk, and then you miss that deadline. If you're listening to our course today as an encore, the links that I've mentioned, the ones that are on our resource slide, those will all be listed in the description of the video. Reason code 39011 is up next, and this is for claims that were submitted more than 1 year from the date of service or the through date, if the claim spans more than 1 day, like most inpatient stays do. Some exceptions have been identified by CMS, and those are things like an administrative error, retroactive Medicare entitlement, or retroactive disenrollment from a Medicare Advantage plan, or a PACE provider organization, Program of All-Inclusive Care for the Elderly. It is important to remember that an error in making a primary payment determination does not qualify as good cause for waiving the timeliness requirement. So if you thought that the patient only had Medicaid and then later on you realized they had Medicare and Medicaid, or you didn't know that the patient was still working, you forgot to ask them questions about other coverage, those types of things don't automatically give you a waiver for being past the time limits. There are also not reasons for requesting an appeal. There was no initial determination, so it's not appealable. If your claim's been rejected for timely filing, your remittance advice is going to contain group code CO, meaning contractual obligation. So it's provider liable. You may not bill the benefit services. And then, like I mentioned, a timely filing rejection is not appealable. We have been told by our appeals department that they do continue to receive a large number of requests regarding other insurance that have been rejected for timely filing. And appeals can't do anything with those requests. Those claims are technical denials. They don't involve a medical determination. Those requests go to our claims department, not our appeals department. And so when you send them to the wrong place or you use the wrong form, it just holds things up for you. And so again, we're here today to try to prevent all that. So at the time a patient is admitted or services are rendered, it is up to the provider, physician, or supplier to determine whether or not Medicare is the primary payer. And we've talked about that. We're asking those beneficiaries or their representatives questions about other coverage. Now, if you believe you meet the criteria for good cause to waive timely filing, there are certain steps that you have to take to have your request considered. And it starts with an original paper claim form. Part A providers have to include a completed UBO4 with a bill type that ends in a 7. You're new here, that indicates that you're asking for an adjustment. You have to include any documentation that's needed to process the claim. You might have a letter explaining why the timely filing deadline was missed. Documentation that proves good cause. And it all depends on the circumstance. This could be things such as reports or a statement from CMS or WPS, an official award letter from the Social Security Administration, verification of recouped payments from other insurance, disenrollment notifications. We talked about Medicare Advantage plans. If they retroactively disenroll, they go out of business, things like that. I do want to remind everybody again, and I know I've said it already, timely filing rejections are not appealable. Don't send your request for a waiver to the appeals department or in a written inquiry to customer service. It's only going to delay handling of your request. It's not going to help anything. All requests have to be sent to the claims manager at the appropriate state-specific address that can be found on our website. We do have an article related to timely filing that outlines all of these requirements. It is included on your resource slide. Again, if you're listening to this course as an encore, look in the description of the video for those links. Reason code 32476 showed up on our 12X list of categories of errors, and this is applied when a hospital provider bills a revenue code that's not allowed on an inpatient Part B claim. Medicare pays under Part B for a limited set of non-physician medical and other health services when furnished to an inpatient of a hospital who is either not entitled to benefits under Part A, has exhausted his or her Part A benefit days, or receives services that are not covered under Part A. So to correct and prevent this issue, we want to check to see if the patient has Part A and has inpatient hospital days available. Verify with the hospital's utilization review committee if the patient didn't qualify for inpatient status. Check your claim against the table in 100-4, Chapter 4, Section 240.2. I do have a link to this on your resource slide, so you don't have to try to write it down here. I do have a screenshot of the table that's in the internet-only manual. That was the claims processing manual. These are lists of revenue codes that are not acceptable on a 12X type of bill. So this should be easy to prevent. It might be that your billing software needs to be updated with some of these revenue codes so that it knows not to put them on a 12X type of bill. Next, we saw a high number of claims where a service was not separately payable. Now, the reason code W7047 and its description is shown here. This is one of those situations where even though the claim or line is unpaid, it might not be an error. I'll let you know what I mean by that in just a second here. So to understand this reason code, you'll have to investigate and understand what else might be going on with the claim or other items on the claim. So you're going to review any other line item reason codes that you might have. Different lines might have unique explanations for their status. It could be that the payment is bundled with another code on the claim. We know this by using what's called a status indicator of a HCPCS code. That might give you some insight into some specifically might tell us that there is no separate payment for the code. I'm thinking of status indicator N. Now, before you submit a claim, review the status indicator for each HCPCS code to make sure that it's paid under the appropriate prospective payment system. If you build an incorrect code, that's easy to correct. Correct it and resubmit the claim. After taking a look at all of the other items on the claim and addressing any possible issues with coding or billing that might be occurring, the reason code might be accurate. It just might be that there simply isn't any reimbursement for that line charge and it's unpaid, but that's okay because the payment is included with something else on the claim. That happens sometimes too. You're going to have to look at your individual claim and your individual situation to see what that case may be. We also had reason code 7049, and that signifies that a service was provided on the same day as an inpatient only procedure, which resulted in a denial of outpatient related line items. So this is because the inpatient procedures are paid under a different system, the inpatient prospective payment system, and aren't considered payable under the outpatient prospective payment system, or OPPS. So the reason code is triggered when a HCPCS code for a service that has a status indicator of C, which identifies it as an inpatient only procedure, is sent on a Part B claim. In this case, inpatient Part B, a 12X. All line items that have the same data service as the inpatient only procedure will also be rejected. And our last reason code pertains to the National Correct Coding Initiative procedure to procedure code pair edits. I know that's a mouthful. Just to give you a little bit of background here, the NCCI procedure to procedure edits prevent inappropriate payments of Part B services that should not be reported together. These used to be called Column 1 and Column 2 edits. So each edit has a Column 1 and a Column 2 HCPCS or CPT code. And if a provider reports the two codes of an edit pair for the same beneficiary on the same data service, the Column 1 code is eligible for payment, but the Column 2 code is usually rejected. Reason code W7040 states that code 2 of a code pair is considered a component of a comprehensive procedure and would be allowed or might be allowed if an appropriate modifier were present. So what can we do about this? We need to look a little deeper. I know in a lot of these situations, it's going to come down to looking at your individual claim and your individual situation. You're going to be like Inspector Clouseau. You're going to have to backtrack and look at what's actually going on to know how to proceed. If the NCCI code pair tables, which are on the CMS website, you have to look at column F And it specifies if you can use a modifier. The number in this column is the modifier indicator for the edit. So the indicators 0 or 1 show whether or not a modifier allows the procedure-to-procedure code pair to bypass the edits. If there's a 0 in that column, it means no modifiers associated with NCCI allow you to use this procedure-to-procedure code pair. When no modifiers are allowed, only the code in column 1 will be paid for the same patient on the same date. If there's an indicator of a 1, that means you could use a modifier with the procedure-to-procedure code pair if and when it was appropriate. After you've reviewed the edit, if your claim is not billed correctly, you can adjust it to correct it. So I hope that looking at those different situations that we saw within the quarter on the reporting period has given you a better understanding of some of the types of errors that we're seeing repeatedly. I know I usually have an eye-opening experience sometimes when something out of the ordinary pops up. I'm used to seeing timeliness, Medicare secondary payer, those kinds of situations. But every quarter something new could pop up. So I hope that, you with your experience and as you learn more about Medicare, it's given you some insight on how to deal with those situations. Now the next two slides contain resources for more details on some of those situations. And I've mentioned some of these before already, so I'm just going to go down the list. And if you've downloaded a copy of the slide deck, you have these links. If not, if you're listening to the encore, scroll down and look at the description of the video. Now the first one that's listed here is a tool on the WPS website for looking up specific reason codes, details, and pointers for correcting rejected claims. And I know we're running out of time, but I want to go out here real quick because I've learned from doing past webinars that some people didn't know that this existed. So on the WPS website, up here in the top navigation, under Tools, I'm going to show you how to get there. Tools, All Tools, scroll down. Right here, this reason/remark lookup. If you have a code on your remittance advice or on your claim, you can enter it here. I'm going to use one of the ones that we talked about. I'm going to use 39011. I know that's a reason code, but if I wasn't sure, I could mark all of these boxes and hit search. Scroll down. So you can see this is the actual narrative of this reason code from FIS. A lot of times they might be cryptic, they might be generic, but it'll tell you information about what that edit is, what your claim has, what situation it might be, and give you pointers on what to do about it. Sometimes, not always, this will also contain links to other information dealing with your situation. So this one is dealing with timely filing. You can see there's another resource or article on our website that deals with timeliness, timely filing. Also another resource that I mentioned, timely filing of claims. When I was talking about asking for a waiver, sending it to the claims manager, all of those types of things, you can find all of that in this article. And this is also on your resource slide a little bit later. I'm going to jump back to the PowerPoint now. Some of the other items that I have here for you, then there's some Medicare secondary payer things, a CMS booklet, excellent resource for those insurances that beneficiaries might have, what the rules are for each of those to be primary or secondary to Medicare. Then we have a special edition Medicare Learning Network publication, also about MSP situations. And then the manual and chapter regarding details about these MSP situations. A couple more for you. First link here is to Medicare Learning Network fact sheet about patients in custody. We mentioned this, incarcerated beneficiaries, how that's defined and what the rules are, what that exception is about billing and collection that we talked about briefly. You can read all of that there. Then we also have the manual and section about the revenue codes that are not allowed on a 1-2X type of bill. Third bullet takes you to Addendum B, which will show you the status indicators for particular codes. So you can check to see if it's separately payable or considered an inpatient only code. There's an article on our website that I just showed you about timely filing. And then finally, the CMS webpage regarding the National Correct Coding Initiative for more information about those code pair edits and modifier usage. Now is the time that we would see if you had any questions. We're out of time here. If you submitted a question, rest assured I will answer that question and I will send it out to everyone that's in attendance today. So I'm sorry that we've run out of time here. You will have another opportunity to send in questions. I'll tell you about that in just a second. Please stay on the line. I have just a few more important items for you before we close. WPS receives a lot of overpayment notifications and refund requests. We know that you want to repay Medicare in a timely manner. However, there can be delays if you use an incorrect or outdated form or you don't follow the proper process. Missing information or sending us a check without explanation as to what it's for are some of the reasons that can cause a delay. To avoid those unnecessary holdups, consider using our portal. The refunds or overpayment claim adjustment features can help you do that quickly and efficiently for processing those overpayments. We also have information about the form available on our website. I'll quickly have Leanne place a link to an article on our website that can help you determine which action to take, which form to use. This slide is a provider alert announcing a change to mail delivery for Part A appeals submissions submitted via SNAP, which is our portal. We're no longer sending paper correspondence. You can see information here effective June 1st. All providers with an active SNAP account who submit their appeals request through the portal are going to get an email now regarding a decision on their appeal, and then that's going to take you and give you immediate access to your appeals correspondence in the portal. Please take a few minutes to complete a survey about this course. Tell us what you liked, what we could do better, suggest topics for future education. We have a few options for you depending on what your preference is on how to get that feedback to us. You can use the link that's in the chat, or when you exit the webinar, you're going to be asked to go to an external site, and that external site is safe. It is the CMS Qualtrics page for the survey. Message is going to look similar to what you see here with the triangle and the continue button. If you're listening to me as an encore, you're going to get a box with a triangle and the finger and the stars here. That's also going to be a link to the survey. Those surveys give us insight into how we're doing and the types of education that you want and need. In a few minutes, you're going to receive an email. It's going to thank you for attending. It's also going to have a link to the survey if you want to use it that way. I don't want you to delete or overlook that email because it contains your certificate of achievement. It has your name and your contact hours. So if you need to turn it in for credit towards continuing education units, I want you to be able to have that. If you don't see it in the next couple minutes, check your junk or your spam folder. Make sure to add the WebEx email address to your safe sender list. If you think of a question later, you have 1 week from today to submit a follow-up question. Send them to our same education mailbox, put today's date, and something about inpatient errors in your subject line. That way they'll be funneled directly to me and I can provide an answer for you. On behalf of myself, Leanne, everyone else in provider outreach and education, I want to thank you for your participation today. We hope to have you join us for future education, and we look forward to your survey feedback. Thank you so much for your attention, everyone. You may now disconnect.